Okay, well, thank you very much for giving me this invitation to tell you what I think osteoarthritis is. This is a disease that really has changed beyond all recognition in the past 20 years. And I think it's a very exciting time to be learning and be interested in it. So I have a few conflicts of interest, some disclosures, and you'll see where these come in. These are all companies that have provided academic support for one of our big studies. So why do we work and why are we interested in osteoarthritis? Well, it obviously goes without saying that this is the most common type of arthritis. It has huge societal burden across the world. And at least when I started working in it, I hope things have changed a little bit, but this was the most unfashionable disease of rheumatology. All of my colleagues were going into inflammatory arthritis. The Kennedy Institute had just discovered anti-TNF therapy in rheumatoid arthritis, and I was sticking my hand up and said I wanted to do osteoarthritis research, and I think they were pretty surprised by that. But I've stuck with it, and it turns out that this is a really important, interesting, a fascinating disease, which is very, very different from everything else that we know about within rheumatology. Of course, one of the principal reasons why we need to work on it is because there are no current disease-modifying treatments in OA, apart from surgical joint replacement. And we know that it affects pretty much every moving part of the body. All your joints are prone to getting osteoarthritis, and the most commonly affected ones are shown there. So we know that there are some very obvious clinical features that we can see in our patients. In hand OA, you get the squaring of the CMC joint at the base of the thumb. You get nodal changes, Bouchard and Heberdin's nodes in the finger joints. You get expansion and increased bony changes in the larger joints as well, although that's often not quite so apparent from a clinical perspective. And when you do an X-ray, you see all of the pathognomonic features of osteoarthritis, which includes reduction of the joint space, so loss of the articular cartilage. You see increased bone formation, both in terms of sclerosis of the bone, so thickening of the bone plate below the most affected regions of the joint. And then you also see these increased bits of bone which form on the sides and often form these sort of lips around the joint, and these are called osteophytes. And when we look by histology, this is a finger joint. You can see that the articular cartilage, which is normally just a millimeter or so thick, particularly in these small joints, it's been stained blue here, but you can see that it is fibrillated, it's broken down in places. In this region of the joint, there is no evidence of cartilage loss at all. That would cause joint space narrowing on an X-ray. Here is a large pedunculated osteophyte on the side of the joint. There is thickening of the synovium, but little in the way of frank synovitis that we'd see in rheumatoid arthritis. And you can't really see it here, but there's some thickening of that subchondral bone plate as well. Now, one of the things that I stress to all of my students is that we mustn't forget that osteoarthritis is a disease of mechanical stress. And epidemiology in osteoarthritis is one of the longest disciplines in research in OA. And it has told us time and time again that if you have mechanical stress in your joint, you will be prone to developing osteoarthritis, even if you're relatively young in age. And so we can think about that mechanical stress as either being increased mechanical load going through a relatively normal joint. So think about contributions from obesity. If you have malalignment of joints, then you have increased stress on the inner surface, as you see in this individual who has bandy knees. Also occupational stresses. If you do things that put a lot of mechanical load on certain joints, you are prone to developing OA. But equally, if not more important, think about when you've got normal load, but going through a joint that has lost its mechanoprotective mechanisms. And you can lose those mechanisms either acutely if you have an acute destabilizing injury of the joint. So think about meniscal injuries or cruciate ligament injuries in a younger individual, for instance. But importantly, you also lose those mechanoprotective mechanisms as we get older, because you lose the muscle support across the joint through muscle atrophy, you lose your gait reflexes, and all of these things normally work to protect the joint as you're using it. And those things are substantially impaired as we get older. And so taken together, osteoarthritis, along with other aging-related features, becomes progressively worse and worse, that risk, as you get older. And don't let anyone persuade you that this is only a disease of weight-bearing joints, because in fact, the mechanical load that is going across the joint is largely the result of mechanical stress due to muscle action across a joint, not due to weight. And so even in joints like the finger joints, the hand joints, they are also highly mechanosensitive. And this is seen very beautifully in this patient who I see in my clinic with my colleague, Fiona Watt. And in this, you can see that this patient has really bad proximal interphalangeal joint osteoarthritis. But you can see it is completely asymmetrical. There's almost complete sparing of disease on the left-hand side. And that is because this patient has previously had a stroke that has rendered her paralyzed on the left-hand side. So that accounts for why she has this very asymmetrical disease. So one of the things that has puzzled people over the years is, well, if it's so mechanosensitive, this disease, then how do the tissues of the joint, principally the articular cartilage, how does it respond to injury? And if you look at the articular cartilage, it's really a very, very simple tissue. So this is a tissue that has relatively few cells. All of those cells are called chondrocytes. It is otherwise made up, 90% of the tissue is made up of extracellular matrix, and that is packing material. It's the collagens and the proteoglycans, as I'll show you in a moment. But the important thing is that this tissue has no endothelium because it has no blood vessels. And when we think about tissue injuries, say the skin injury or bone injury, we think of a very early event, which is the damage to the endothelium, activation of platelets, recruitment of leukocytes, activation of the clotting cascade. And none of those happen in articular cartilage when you injure it. Nonetheless, if you take a knife to the articular cartilage and you simply cut it, you see activation of a whole host of pathways, suggesting that this tissue is nonetheless able to respond very, very rapidly to mechanical signals. And work that I've done in my lab over the past 20 years has really tried to understand, how does this tissue respond to injury? What type of injury is it responding to? And what are the consequences of this injury? And to summarize that, and this is not a basic science talk, I promise, but to summarize what we've established is that there are two principal ways in which you can respond to mechanical injury, either by increased shear stress on the surface of the joint. And this happens, of course, in an unstable joint. And that shear stress or friction on the surface is sufficient to trigger something that we've called mechanoflammation, which means that inflammatory signaling pathways can be triggered in the absence of an immune cell or an inflammatory cytokine like TNF or any of those other molecules. And that can activate pathways that we know are important in osteoarthritis because it can drive the metalloproteinases, the enzymes that cause breakdown of the matrix, and it can also induce molecules that we know are important in pain, such as nerve growth factor. I'll come back to some of these things later. And then conversely, if you squeeze your tissues in a significant manner, just trying to find my mouse, then you can also activate different pathways, and that is through the release of growth factors. And in fact, all the work that we've done in the lab suggests that when you squeeze and compress your cartilage hard enough, what you actually do is promote a repair response through these growth factors. And we think that the balance of these two pathways is really critical for the outcome of your tissue. Okay, so this is sort of already sounding a little bit different from what the textbooks say. And what I want to do in the rest of my talk is to take you through some of those really fixed, old false beliefs in osteoarthritis and try to persuade you this is really a very different disease in the 21st century, or at least in 2024. So I'm going to take you through what I believe to be the fake news in osteoarthritis. I'm going to go through each one of these in turn and try and persuade you that each one of these is actually fundamentally wrong. So the first thing that you would have read in the textbooks, or at least if you speak to our orthopedic colleagues often, they would say to me, oh, well, don't be silly. Osteoarthritis is just a wear and tear disease. It's just wearing down of two surfaces like a tire wears down on your cartilage. And that is really far from the truth. As I've already alluded to, this is a biologically active disease. The second thing that you hear a lot about, and I'll show you some of the consequences of that, is that this must surely be a disease a little bit like rheumatoid arthritis, driven by inflammatory processes, immune-mediated or synovitis-mediated, that would constitute more classical inflammation, and that we should be able to target it and to help our patients. Not true. Cartilage cannot repair itself. All the textbooks and review articles seem to say this, but I'm going to show you some evidence where it's really clear that cartilage can repair itself. And osteoarthritis is a disease of multiple different sorts, different flavors, and it's not really one disease at all. And again, I want to contradict this, and I'll show you some big human data that we've just completed a big study, which I'll show you at the end of my talk. Okay, so osteoarthritis is simply due to wear and tear. I've already mentioned this. This is an actively driven disease. The breakdown of the cartilage from a normal joint into this sort of eroded joint, where the matrix components, the type 2 collagen and the aggrecan, the proteoglycan, are broken down, is mediated through active proteases, so enzymes, matrix degrading enzymes that break this down. And we know that from some old studies now in mice. If you induce osteoarthritis by giving mice a footballer's injury, so you make the joint a bit unstable surgically, you can significantly reduce that disease by genetically deleting those key enzymes that are breaking down the cartilage. So in this case, we're talking about one of the key enzymes that breaks down the proteoglycan, the aggrecan within cartilage, which is called ADAMTS5. If you also delete the enzyme MMP13, matrix metalloproteinase 13, which is a key collagenase, so it breaks down type 2 collagen, mice are also protected from disease. And in work that we published a few years ago, we've been able to show that these metalloproteinases are highly mechanosensitive in the joint, because if you induce osteoarthritis in mice, but then you don't let them run around on that joint, so you immobilize the joint, not only are they protected from osteoarthritis, you also don't see the induction of those matrix metalloproteinases. So in other words, osteoarthritis is a biologically mechanosensitive disease, which is therefore, to my money, a targetable disease. So the second point, fake news, is that osteoarthritis is driven by classical inflammation. And this really stemmed from this largely true, I think, balance between catabolic and anabolic processes going on within the joint, driven by these proteases, and the false belief that just because inflammatory cytokines can drive these things as a model in vitro, in the test tube, that these inflammatory cytokines might be driving it in the human. And that was really not true at all. And that was evidenced by a number of clinical trials. These were in repurposed rheumatoid drugs like hydroxychloroquine and anti-TNF and anti-IL-6 and other anti-inflammatory drugs such as anti-IL-1. And every single one of these randomized controlled clinical trials in osteoarthritis failed to meet its primary endpoint. So this is not the driver of osteoarthritis. I'm going to talk about what I think are the better targets for OA in my next talk. Okay, so cartilage, can it repair itself? Well, as I say, every textbook you read, you'll find evidence of somebody who says there's no evidence that cartilage can repair itself. Well, I put it to you that it's really difficult to find evidence that it doesn't repair, or indeed that it does repair if you're just looking at an OA population. Very hard to know what happens in our joints over a lifetime, because we can't really measure this actively. But one of the very interesting observations that's come out of recent studies is work done on this surgical procedure called surgical joint distraction. And these studies have largely been done in the University of Utrecht in the Netherlands, but there are other cases across the world where this procedure is done. This external fixator is usually applied for very complex fractures, but in this case, what it's being used for is taking patients with end-stage osteoarthritis. So these are individuals with grade 3 or grade 4 Kelvin and Lawrence osteoarthritis. They're a little bit younger. So these were individuals in their 50s and 60s in whom they were told, look, you're too young to have a joint replacement, but why don't we try this treatment on you? We'll put this distractor device in, it's inserted into the bone on either side of the joint, and then the joint is distracted, it's put under tension, so the joint is pulled apart by half a centimetre or so, and then the individual has this in situ for 6 weeks, and then at the end of 6 weeks, it's removed and the patient is rehabilitated. And this was one of the bigger cohorts. This is 20 individuals. There's no placebo group in this study. But what you can see from this graph at the bottom here is that there was a very substantial and importantly sustained reduction in pain in these individuals. And this goes right out to 24 months, even though the distraction period is just for this very short 6-week period. And they also have an improvement in their WOMAC functional score as well. So that all looked very positive. But the most surprising thing is that when they did MRI scans, and here's an example of an MRI scan taken at baseline in one individual, the same individual a year later, and then 2 years later, what you can see, so these are coronal views with the cartilage, because it's got water in it, showing up white. And you can see that in this most affected region of the joint, there is bone-on-bone articulation here, but at 1 year, there is now some white tissue that has appeared between the two surfaces, and then at 2 years, that has further increased. And that was statistically significant in terms of the mean articular cartilage thickness over that 2-year period, and also the reduction in the amount of bare area where the erosion of cartilage was right down to the underlying bone. That was quite strikingly reduced in these individuals as well. So this suggests that if you correct that mechanical environment in the joint, actually there is great capacity for this tissue to repair, and it seems to be a sustainable repair in that this tissue can now be walked on beyond that 6-week period, and it's still there at 2 years. So perhaps that was a bit of a surprise. A lot of people still find these surprising data, but it aligns really well with some of the big studies now that are coming out looking at genetics. So we've lagged behind a little bit in the osteoarthritis fields in terms of looking at genome-wide association studies. But now, thanks to many collaborators, largely across Europe, we have the biggest osteoarthritis GWAS studies to date. And these have identified over 100 different risk variants in the genome that are associated either with increased or decreased osteoarthritis. And specifically, they've been able to at least try to pinpoint 77 what they call high confidence effector genes that they think are actually responsible for this effect. And if you take those 77 genes and you superimpose them onto that schematic I showed you before, what's really striking is that so many of them sit on this repair side of the pathway. They're in growth factors that we have associated previously with being released upon compression. So the FGF pathway, the TGF pathway, they're all present within these genetic hits, and probably other pathways as well associated with repair. There's one gene that we associate with this mechanoinflammatory pathway, and I'm going to talk about that in my next talk. But for now, I think the data is compellingly telling us that the genetic risk associated with OA is actually because we don't have the genes that allow us to repair cartilage effectively. And that is what seems to be coming out of those genetic studies. And by extrapolation, it probably also means that these are the targetable pathways. So more of that in my next talk. Okay, so just in the last 5 minutes, I want to tackle this thorny issue of whether osteoarthritis is one disease or whether it's multiple diseases. And of course, when we look at the patient, many people have described different phenotypes in osteoarthritis. Here's a very complex paper showing all sorts of things. Perhaps the ones that we would recognize clinically most would be post-traumatic OA as opposed to age-related OA. We tend to talk about something called metabolic OA, which is largely driven by obesity. So we know that's one of the strongest risk factors in disease. And then, of course, we talk about inflammatory OA or synovitis-rich osteoarthritis, which we might particularly see in the hand. So the real question is, do these phenotypes actually correspond with distinct molecular endotypes? So are they all being driven by different pathways, or are they actually one disease, but just looking slightly different in different patients? And that's, of course, really important as we try to focus our disease treatments and understand the targeting of osteoarthritis in patients. So we try to address this. This has recently been submitted for publication, so you're seeing it hot off the press. This is called the Step Up OA Consortium. It stands for Synovial Fluid to Define Molecular Endotypes by Unbiased Proteomics in Osteoarthritis. I'm not going to show you a huge amount of science. This is a really big international cohort supported by industry, which I mentioned those earlier. And the principles of Step Up OA is that we recognized we were going to have to do this in really large numbers of patient samples. So the total analysis was in over 1,700 individual samples. About 1,400 of those are in osteoarthritis, primary osteoarthritis. We needed to do a molecular analysis that was, again, broad and agnostic. So we looked at a platform called the SomaScan platform, where you can measure 7,000 proteins from a very small volume of samples. And we did this on the synovial fluid from individuals with established osteoarthritis. And we had matched cross-sectional clinical data, both pain and structural data on each one of these samples for every patient within this study. And I'm not going to tell you in great detail what we found, but I'm going to give you the top level result, which is that when we did in that 1,400 individuals, when we did an unsupervised cluster analysis and said, tell me whether there are individual distinct molecular clusters within osteoarthritis, or whether this is just a range, a continuum of disease, we found that this is indeed a single disease. There's no evidence of clustering within osteoarthritis, and this is a continuum. There's a lot of change in the biology, but there are patients sit anywhere along that continuum, not in distinct bundles. If you want to read that paper, you can find it on bioRxiv and scan that QR code there. What it did tell us is that osteoarthritis is primarily a disease of this epithelial to mesenchymal transition. If that doesn't mean anything to you, it didn't mean much to us when we first looked at it. What this means is that this is a tissue remodeling phenotype. This is what you have when tissues are injured and when they're trying to make a repair response. And so this fits with, I hope, everything that I've just been telling you about the mechanical response and the ability of this tissue to be able to repair appropriately to that. That's not to say that there isn't any inflammation. You see activation of the complement pathway, you see coagulation, you see angiogenesis happening. So there's plenty of biology in there, but the core pathway is telling us that this is a disease of joint tissue remodeling. And so if we think now about those phenotypes, whether it's age-related or trauma-related, whether it's inflammatory, whether it's obesity-related, we can really, I think, say that osteoarthritis is not multiple diseases converging onto a common pathology, but is actually a single core disease where some of these other things probably influence the outcome, but they are not the primary driver, and therefore they probably don't warrant individual treatments. So just to finish off then, what is osteoarthritis? Well, I hope I've persuaded you. This is an active, biologically driven disease. It's driven in part by this mechanoinflammation, but it's not driven by the classical immune-mediated or cytokine-mediated inflammation. The cartilage definitely does have the ability to repair itself. That may get less good as we get older. We don't fully understand that yet, but it certainly can repair, and we're beginning to understand the mechanisms by which it repairs, and that this, thank goodness, is one disease, and that is going to help us as we really try to define pathways for the future. So with that, I would like to finish there, acknowledge my funders, all my colleagues in the Step Up OA Consortium. There are too many of them to list here, and also to you for listening. And I'm looking forward to telling the next bit of the story, which is where are the new treatments really going to come from in osteoarthritis? Thank you.